guys, welcome back to the Teach Back Method, where I teach you guys something I'm learning about in grad school to help me understand it better. For today's video, I'm going to be discussing brachial plexus injuries in infants. Let's break it down. Starting off, what is a brachial plexus injury? As the name suggests, this is an injury to the brachial plexus, which is a network of nerve fibers that innervate the skin and musculature of the upper extremity. The mechanism of injury is mechanical, as it often happens when a lateral traction is applied to the baby's head or neck during delivery. This force is typically applied when the baby has shoulder dystocia, meaning that the shoulder is stuck inside the canal during delivery. Thus, an external force is required to get the shoulder unstuck and to get the baby out, as this is a medical emergency. The prevalence is about 0.3 to 2 per 1,000 births. More commonly, injury to the upper brachial plexus is more commonly injured than the lower brachial plexus. The upper brachial plexus, as I previously stated, is commonly caused by lateral traction to the head or neck. In contrast, injury to the lower brachial plexus can be affected if an arm is pulled rather than pulling from the head. There's 3 different types of nerve damage that we might see with a brachial plexus injury. The first one and most severe is called avulsion. This is when the nerve root is entirely pulled and separated away from the spinal cord. Unfortunately, surgery cannot always fix this. Another type is called stretch, and as the name suggests, this is when the nerve is mildly stretched. Now, this can be repaired without any treatment. It can go away on its own, or it can be fixed with mild non-surgical treatment. Prognosis is very good, as this child should be able to obtain full and normal function. The last type is called a rupture, and as the name suggests, this is when the nerve is partially or fully separated or ruptured from it, and sometimes it can be repaired with surgery. So if we're looking at worst to best case scenario, the best case scenario is with stretch, then rupture, then our most severe form is avulsion. Next, I'm going to discuss the 3 types of brachial plexus injuries. The first one I'm going to talk about is Erb's palsy. Now, this is when damage happens to the C5 and C6 nerve roots. Now, if you want to think about what is this presentation going to look like, just think back to which muscles that these nerves innervate. So we should be expecting paralysis of the biceps, rhomboids, teres minor, supraspinatus, infraspinatus, deltoid, and brachioradialis. A more severe form can also include C7, so remember that innervates our triceps. And then lastly, we will be expecting a waiter's tip hand presentation. So what that's going to look like is something like this. The second type is called Klumpke's palsy. So we're going to move down the chain. So this is when damage occurs to the C8 through T1 nerve roots. Now once again, think back, what do these nerves innervate? So we'll be expecting paralysis of the pronators and wrist flexor muscles. Because of this, we're going to be expecting what's called a claw hand presentation. So it'll look something like this. So the hand will be supinated because the pronators are paralyzed, and the wrist is going to be extended because the wrist flexors are paralyzed. The third type I would like to talk about is called Horner syndrome. Now, this is commonly seen with Klumpke's palsy, which is the previous condition that I just talked about. So Horner syndrome is usually in the T2 to T4 region, and when it is associated with Klumpke's palsy, we're going to think of total upper extremity paralysis, everything above that. Now, this is accounting for about 10 to 20% of brachial plexus injuries, and the presentation associated with Horner syndrome is including a drooping eyelid, excessive pupil constriction, and diminished sweat production in part of the face. Here are a few of the risk factors that may contribute to a brachial plexus injury during delivery. The first one is the baby being large, a large birth weight, so this is classified as over 8.8 pounds. The next one is a long and difficult labor. The next one is assisted delivery. Now when I say this, I mean assisted by forceps or a vacuum. The next one is the breech position. The next one, shoulder dystocia. So when the mother has had a previous birth, if shoulder dystocia occurred in that baby, it's more likely to be a possibility for this baby, maybe just based on the mother's anatomy. And then the last one, siblings with obstetric palsy. So once again, in the mother's previous children, if any of the siblings of this new child has obstetric palsy, the risk factor for this baby also does go up. The last thing I would like to talk about is medical management or nerve repair. So these are all going to be various surgeries that can be done in an attempt to repair the nerve. So the first one is called neurolysis. So this is when we are freeing up the nerve by getting rid of the excess scar tissue that surrounds it. The next type is called neurotization, and this is when we are dividing an intact nerve and we're transferring it to a distal denervated nerve. And then lastly is nerve transplantation. We're actually taking a donor nerve, typically taken from a part of their body where it's less important. We're transferring it to our baby, and we're using it to connect two healthy ends of an injured nerve. So if we're thinking back to all the different types of injuries that can occur to the nerve, this would be appropriate for our ruptured nerve because they're already separated. So with the donor nerve, we're able to connect them, and then it should grow into healthy tissue. Now, things like this, especially neurotization, are best in practice if they're used within 5 months of injury. I hope you guys learned something today. Come back to my page to learn more.